Hey everyone, my name's Fraser. I'm a doctor in Australia and I'm going to present a case that I saw where I used some ultrasound to diagnose pleural effusion and essentially help me clinch a diagnosis on the wards in the middle of the night. So just to begin with some learning goals, we're going to aim to understand a basic and visual approach to diagnosing pleural effusion with ultrasound. Our objectives, we're going to describe landmarks to place the ultrasound probe and be able to visually assess the lungs, hearts and inferior vena cava to support or refute a diagnosis of pleural effusion. So the case is an 80s female admitted for IV flucloxacillin for infective endocarditis. She needed a 6-week course and she wasn't able to cope at home, so she was admitted more for social reasons. She's got a history of previous rheumatic heart disease with heart failure and mechanical valve. During her admission, it was complicated by very low potassium, which was thought to be a side effect of the flucloxacillin, and the DANU team had been giving many mini bags of 10 millimole potassium. So I met the patient in the middle of the night and I was called to them because they were complaining of claustrophobia and were quite anxious and the nursing staff were concerned. The previous medical officer had charted a 1 litre bag of 40 millimole potassium, given some temazepam for difficulty settling and feeling claustrophobic, and then went home, and I had taken over that night. So just take a moment at this point to think through what are your diagnoses as you're walking towards the patient in the hallway. You know, your assessment doesn't start when you enter the room, it starts the moment you get the call when you know this basic information and you start walking towards the patient. You start anticipating your issues. So at this point, I kind of briefly knew the patient just from what the nursing staff had told me. Obviously, we're thinking of significant cardiac history, just being given a 1 litre bag of fluid that's just run through. You know, could this be acute pulmonary edema? Could this be part of the heart failure prodrome? Could this just be anxiety? You know, these are the thoughts that are running through my head. So I guess at this point, it's worth just pausing and just thinking to yourself, how might you assess this patient in the middle of the night? And what's your approach? So for me, when I enter the room, I like to begin with the doctor's ABCDE approach. So danger/drugs for this lady. So she had the potassium running when I walked in the room, so I stopped the bag just in case it was related to that. Response-wise, she was alert. She appeared anxious and gasping for air. She stated she felt like the cardiac monitoring leads were strangling her. In terms of send for help, I always just think over this one and ask myself, do I need more help in the room right now? At this point in time, I felt comfortable managing the patient, so I didn't call for help initially. Airway-wise, she had a patent airway, gasping for breath, nil stridor, able to speak in broken sentences. Breathing, she was saturating at low 90s on 4 litres nasal prongs with a rest rate that was quite high at 26, with no previous history of oxygen requirement, so this is a new oxygen requirement. Her lungs were clear but reduced air entry in the bases. Circulation-wise, her hands were warm and well perfused, palpable peripheral pulses. She had an irregular radial pulse. Her heart sounds were dual, though quiet and difficult to appreciate any murmur. And her ECG showed atrial fibrillation with a right bundle branch block with multiple PVCs. She had 1 cannula in situ in the cubital fossa. Disability-wise, she was GCS 15, moving all 4 limbs, sitting up in bed. In terms of environment and extra history, so she's afebrile, her last potassium was 2.2 prior to the 1 litre bag of 40 millimole being hung. Her advanced resuscitation plan stated not for resus, for only ward-based cares. So now that you know that extra information, you need to start thinking of, well, what's going on? What's happening with this patient? So a way to also break this up is what's most likely, what do you need to consider, and what are your must not miss diagnoses? Now, these are the things that at the time I thought were the most likely, and that was acute pulmonary edema versus pleural effusion or both. I needed to consider whether this was related to hyperkalemia, as she just had the bag hung, but also whether this was hypokalemia. Pulmonary thrombus and pulmonary embolism are always in the back of my head when I see these patients in the middle of the night. And my must not miss diagnoses If you can't think of anything at all, you can always fall back to 4 H's and 4 T's. So hemorrhages, hyperkalemia and other electrolyte disorders, hypoxia, hypothermia. In terms of your T's, it's toxins, thrombus, tamponade and tension pneumos. Just to remind you, this is a small rural hospital, so we are limited in the investigations we can do. If I order bloods, it's most likely just going to be a venous blood gas or an arterial blood gas. Or if I want to get some sort of imaging, I need to call someone in. Or if you've got the skills and can do an ultrasound, there is an ultrasound machine on site. So just a little bit on point of care ultrasound, also known as POCUS. So really it's not a diagnostic medium, it's a clinical aid to guide decision making, i.e. it's the modern stethoscope. It's going to help you in guiding your next steps in management and whether you're going to order further imaging or not, or can make the diagnosis based on what's clinically in front of you with the information you have and that you gather from the ultrasound. So to perform a point of care ultrasound, you need to have an ultrasound machine. There's different probes that you'll come across, and there's usually 3 sort of basic probes, and that's your linear array probe, which is the flat one, a phased array, which is the cardiac probe that some people might refer to it as, curvilinear probe, which is the probe usually used in fast scans and abdominal scans. You also need a little bit of knowledge of basic landmarks and basic anatomy. And lastly, you need practice. You need to really just get a probe and an ultrasound machine and have a go at actually interpreting what you're seeing and putting it on people and figuring out ways to get around rib spaces and all of the problems that you'll run into. And nothing beats hands-on experience. So I've just got 2 pictures here. Unfortunately, I don't have the curvilinear probe on here, but you can see on the left there's a linear probe which is flat. You've got a phased array, which is the cardiac probe, which is on the right. You can see there's numbers on them, 15 to 6 on the left and 5 to 1, and that's your millihertz. And the higher the millihertz, usually the more detail, but you can't go as deep into the tissue. And you'll see that your curvilinear will sit somewhere in between those 2 numbers. So now back to our patient. So they're sitting up in bed, and if you can imagine, this is them, just the outline. And where I've got the speaker with some sound marks is where I'm placing the probe. So the first place I put the probe is on the right, sort of lower axilla area, and I find the liver and then sort of work my way superiorly until I find a lung or whatever, or the diaphragm. And then in this particular patient, this is what I see. So you can see that there's liver inferiorly. You can see a vessel somewhere amongst in that liver. You can see a lot of black, and then you can see something flopping around, and that's essentially called a jellyfish sign because that's collapsed lung and there's fluid all around it. I then switch to the other side in the same place and I look. And this is what I see. So again, similar to the other side, I can now see spleen that's on the left. That's just inferiorly. The diaphragm is sort of the brighter bit just sitting above the spleen, and then it's followed by black area. And again, you can see something flopping around as the person tries to breathe, and that's collapsed lung with fluid all around it. And if you look closely, you can see on the left side something moving, another black dot, and that's the heart that you can see all the way from where I'm putting the probe because of the fluid. Now these are the same images, but I've just put them up next to each other and larger so you can see. And so on the right hand side of the patient, collapsed lung with fluid all around it. And then you can see on the left hand side of the patient, again, collapsed lung, and you can even see the heart just on the left side of that image. So here I'm using focused ultrasound to answer some questions for me. So I guess my questions were, is there pleural effusion and is it bilateral? And the answer is yes for both of those questions. And just as a side note, you can also estimate pleural effusions with ultrasound, and it's usually the maximum distance from the lung to the diaphragm or chest wall in centimetres multiplied by 200, and that'll equal your volume in mil. So it's rough estimation and it can just give you an idea of the volume. So coming back to our patient, I've been able to demonstrate now that there is pleural effusion and it's bilateral, which fits more with this cardiogenic sort of pathology and this history the patient has. But next I can look at other areas of the lung and the heart and the inferior vena cava to help me in clinching this diagnosis and reassuring me that I haven't missed anything. So now we're looking at a rant and lant view of the lung. So we're looking more at the apices and superior anterior aspects of the lungs, and it's called rant because it's the right anterior aspect and lant because it's the left anterior aspect. So you'll see on the right hand side of the patient, when they take a breath in, I can see that there is marching ants of the pleura at the superior aspect. I can see that there are what are called B lines coming down. I'm looking between one rib space here. So it's normal to have up to 3 B lines, and those B lines are those sort of shadowy projections going down. And in this patient, they're almost uncountable. When they take a breath in and you try and pause it, you're probably going to see 3 plus 4, 5 maybe, and they look quite homogeneous and it looks like a snowy kind of picture. We then come to the left side, so the lant view, and again I can see a similar view. I can't even really see the B lines, but basically the B lines, there's so many that they've become homogeneous and there's actually quite this sort of snowy kind of picture. So now we'll just quickly compare it to a normal view of the lungs. So down the bottom, now you can see there's sliding of the pleura, that marching ant sort of sign, and then this is between one rib space, and you can't really see many of those B lines, and which is normal. And then when you come up to your top ones, when they take a breath in, lots of B lines, this homogeneous kind of appearance. And then again on the right side, lots of these shadowy B lines. And then we'll look at the normal lung again. You can see there's not really that many B lines, if any at all. And it looks like there's more sort of, even the lung just looks like there's more air in it, where the other lungs look very snowy. Now, with our patient, I then had a look at the heart, and I just did an apical view on this patient because they were quite agitated. So the heart, I've just got it in the mid-clavicular line on the left, just below the nipple, probably at the 5th intercostal space, and I'm angling the probe inwards as if I'm hitting their opposite shoulder blade. And this is what I see. So looking at this heart, you don't need to really have seen too many to look at this heart and think maybe it's beating a bit off. So you can see that that apex compared to the base is not this nice syncytial beating. You've got a fixed interatrial septum, which is the bottom 2 black spaces, which are the atria. And it just doesn't look quite right. And then we look at subcostal space, and I'm looking at the inferior vena cava. So with that cardiac probe, I'm just angling it down, almost looking straight down through the patient to their spine. You'll see sometimes you'll catch the aorta and sometimes you'll catch the inferior vena cava. If you want to tell the difference, the aorta is usually a bit smaller and will pulsate. And you can also put a bit of colour over it, and the colour will show pulsations. the inferior vena cava, you can get a bit of pulsation in it, but it just looks different, and you'll find what's called the middle hepatic vein that runs off it, which you can see in the upper aspect of the image that I'm showing you now. And you can see it's quite big. I'm asking the patient to sniff while I'm looking at it, and it's not really collapsing, so it's dilated, it's not collapsing more than 50%. For me, this is enough evidence to say it's fluid overloaded. So now putting it all together, I can see that I've got bilateral, snowy looking lungs. And this is also known when you have more than 3 B lines as interstitial alveolar syndrome. And there's really only 3 causes for it, and it's to do with consolidation. So you've either got fluid in the lung, you've got pus in the lung, so it's pneumonia, or you've got lung collapse, so lung in lung essentially. And they're the 3 kind of bits, and part of that lung on lung is whether they've got interstitial lung disease as well, can also give you that picture. So, they're my 3 differentials, and this lady's got a terrible heart that's not really beating very well, and it looks quite overfilled. You've then got this inferior vena cava that fits with an overfilled picture as well. So this is all pointing towards a cardiogenic cause, most likely going to be an APO for her shortness of breath. So I was able to answer more clinical questions I had. So is the patient fluid overloaded, which they were? Is there evidence of heart failure? Although I didn't do a formal echo on the patient, the heart's not beating well, they've got this history of heart disease. This all really fits with this heart failure picture and backed up blood with this dilated inferior vena cava. And is there evidence of APO? Well, I've got bilateral pleural effusions, bilateral B lines in both sides of the lungs, and that's fitting with this interstitial alveolar syndrome. It most likely is an APO at this point. And then I have to ask myself, well, have I missed anything? So the 4 H's and 4 T's. On the assessment I've done, the 4 H's and 4 T's seem less likely, although with a PE you might get a dilated inferior vena cava with a blown out right ventricle. Her right ventricle wasn't blown out, so it makes me think less likely it's that. And also clinically, she wasn't really fitting with this. Everything was leaning towards an APO. So to summarise the case, this is an 80s female admitted for flucloxacillin for infective endocarditis. She had known rheumatic heart disease with heart failure. She was in rest distress of a new oxygen requirement in the context of a 1 litre bag of 40 millimole potassium being charted overnight. Her bedside ultrasound confirmed bilateral pleural effusion. She was overloaded hemodynamically with a dilated heart and evidence of pulmonary edema. So I managed her as an APO. So I diuresed her with furosemide and spironolactone with strict fluid balance and potassium and magnesium given, aiming for output greater than input. She improved over 48 to 72 hours and was discharged home post her antibiotic 6-week course. And here's that patient's chest x-ray. So I didn't order one in the middle of the night. I used ultrasound to guide my management throughout the night. In the morning, ordered the chest x-ray just to complete my assessment and make sure we're not missing anything else. And as you can see, it doesn't really help us. It just shows that there's a lot of opacity in the lower zones. But really, you can't definitively say, is that consolidation, is that fluid, where the ultrasound could say to us, that is bilateral pleural effusion. And you can confidently, based on the other findings on the ultrasound, say this is likely an APO cardiogenic picture, where a chest x-ray, you can't ultimately say that. You can only say that there's opacity or not opacity. Lastly, take-home messages. So bedside ultrasound is easily accessible. You just need to have those skills and a little bit of practice to be able to use it. A visual assessment as part of a point-of-care clinical ultrasound or a POCUS can help direct clinical decisions, as it did for me in the middle of the night. And as a bedside clinical tool, it is valuable in answering simple diagnostic questions or questions that will help you in determining treatment for the patient. For example, is there pleural effusion? Yes, no. And unless specifically trained, its limits should be respected. thank you for your time, and if you get a chance, visit my website. I have a few more cases on there and sort of trying to collect clinical pearls that I can share with people.